Okay, good morning or good afternoon, everyone. Welcome to the July 13th EMS Interoperability Task Force call. I'm Josh Legler. We've got some great topics for today. Our core topic is going to be an overview of standards and profiles. So we'll be getting into that today. As with the last meeting, we've kind of moved to a more moderated format for our calls. So we welcome discussion throughout the call, questions and additional input, and would ask that you raise your hand if you'd like, using Zoom, if you'd like to have a chance to say something. And then there's also the chat, that can be used as well. We'll try to keep what's said in the chat integrated into what we're talking about as well. So here's where we are in the big picture of things. We worked on the sequence diagram in June. We're going to talk about that a little more today, just talking about our plans for updating the sequence diagram based on all of your input that you provided last month. Today, we're going to be looking at an overview of standards and profiles. So Amit will be taking some time with us talking about IHE profiles, how they're structured, how to read them, what they cover, how they relate to HL7 and other standards. So that's where we'll be for a good part of the call today. But we have a couple other things as well that we're going to throw into the agenda today. Just as a quick heads up or reminder before we get started, the NEMSIS annual meeting is coming up August 23rd and 24th, and we have an interoperability workshop for EMS vendors scheduled as a pre-conference session on Tuesday, August 22nd in the afternoon. Lunch will be provided. You can go to the NEMSIS website and find the 2023 annual meeting, where you can register for the annual meeting. There's a fee for the annual meeting. And then this workshop is an additional option that's no additional cost. So you can sign up for the annual meeting plus the workshop. In that workshop, we'll get kind of a 101 on HL7 and fire from the Interoperability Institute. We'll talk about things we've learned so far in this task force and hopefully help some of you EMS software vendors to get teed up to participate in the next IHE Connectathon and the HIMSS 2024 Interoperability Showcase. Okay, so on deck for today, we are going to take a few minutes up front to hear from Marcel Powell, who is from Health Gorilla. Health Gorilla is one of the organizations that has applied to be a qualified health information network under TEFCA, the Trusted Exchange Framework and Common Agreement. So they join companies like or organizations like eHealth Exchange, Commonwealth, No2, and a couple others, Epic being one. So Health Gorilla has applied to be a QHIN. They have a network offering today that is available. And so Marcel will be talking about that. After we've covered that, we're going to just give you a brief update on how we plan to refine the sequence diagram that we reviewed last month and make some changes based on the feedback that you all gave us. And then third, I'll move over to Amit to give us the overview of IHE profiles and related standards. So that's today's topics. The main questions that we're going to try to really come up with the answers for today are around the IHE profiles and standards, making sure that we really have a good understanding of those after Amit's presentation. So we'll get into that part in a bit. But first, we're going to head over to Marcel. He'll take some time this morning to introduce Health Gorilla's network and how EMS software vendors would potentially connect with that network, and then plenty of time for questions and discussion as well. So Marcel, I'll let you introduce yourself and Health Gorilla and take it from there.
Thanks, Josh. Really appreciate the introduction and having us here today. I'm going to share my screen. And before I share my screen, we've got a couple other people from Health Gorilla on the call today as well. We've got Avery. She's on our strategy team, and she'll talk a little bit about TEFCA and QN. I'm going to do the first part of this presentation. And then we've got Nick Biala on the call as well. He's one of our sales engineers, so any technical related questions you guys have, he can answer those. Are you able to see my screen?
Looks good.
Perfect. So when you look at, our mission here at Health Gorilla with all the barriers to care in the U.S. healthcare ecosystem, including, limited resources and access to care in the underserved community, our mission here at Health Gorilla is pretty simple. We want to connect everyone, everywhere with actionable health data to create a more equitable healthcare ecosystem. So these are 3 stats that I want to draw your attention to. Important clinical information is missing in 1 in 7 visits. 50% of patients can't recall their medical history, and clinical data gaps are the leading cause of medical errors. So even missing just a few pieces of clinical information can negatively impact the care that you're able to deliver and the outcomes that drive your business. Without that full insight into patients' prior care, there may be unnecessary repeat testing or harmful contraindicated drug interactions. So despite the progress we've made with interoperability, patient data remains, largely fragmented and siloed, preventing informed clinical and administrative decisions. Overcoming siloed health data isn't easy. Exchanging health information between disparate EHR systems is costly and time consuming. The average health system has 18 different EHR vendors. If they're working out of different systems are not designed to talk to one another, meaning that, you have to be the translator, which is something I'm sure that you guys could definitely relate to. So building an accurate patient matching system requires weeks, if not months, of engineering time. Most health information networks and organizations can't afford to build their own system. Point-to-point connections, lack the comprehensive longitudinal patient data that patients need, and without the complete actionable patient histories, physicians are unable to provide the most effective care that impact health outcomes. So today I'm going to be focusing our conversation on how Health Gorilla can help achieve better outcomes by providing you with the complete patient record, direct messaging functionality, and the ability to be able to get post-encounter data from the hospital to track patient outcomes. When you look at Health Gorilla's approach to data exchange, it's fundamentally different than anything else you'll see in the space. One reason for this is that we believe that we should be acting as an intermediary in a national network of clinical systems and care sites. There's no right or wrong way to tackle this. There's just different ways, and we believe our way is the best way. You say, well, Marcel, how is yours better? We see these 3 basic models of connectivity throughout the ecosystem. The first one I'm going to talk about is, point-to-point integrators, or what we call pipe builders, connecting from point A to point B. Anyone could go out there and get that direct connection to an Epic or a Cerner, and get that direct connection with a limited provider network. The problem with this approach is that they're not built on FHIR standards. They're not aggregating the data, and it's a very labor-intensive process. It's expensive, and it's not a scalable model. The middle model that you see here is what we call screen scrapers. This model is fundamentally flawed because it requires a patient to remember their entire medical history and everywhere they've been. It also requires a portal registration and login credentials. So let's just pretend that Marcel, the patient, remembers everywhere that he's been along the way and all of his usernames and passwords. You're still going to have, low utility, limited access to data, and it's very expensive as well. So what we did at Health Gorilla is fundamentally different. We're one data platform, one master feed based on FHIR standards. Not only do we provide you with access to a nationwide network of high quality clinical data, but we're able to provide you with an aggregation engine that does the heavy lifting for you through this data enrichment process, where we're consolidating the patient record into one longitudinal record. So at its core, Health Gorilla is a network of networks that simplifies your workflow by giving you access to this curated data through just one connection, making us the permitted protected custodian for your secure data exchange needs. When you look at this slide, this does an excellent job of encapsulating the depth and breadth of our Patient 360 product for medical record retrieval. As I mentioned, we're a network of networks that connects the Commonwealth, Carrier Quality, and eHealth Exchange, the three largest health information networks in the country. Carrier Quality is actually the framework that allows all these different health information networks to share data with one another and brings in all the major EMRs that you see off to the left, the Cerners, the Epics, the Allscripts, the ThenaHealth, Meditechs. Commonwealth brings in a very large number of the provider groups, and with our connection to the eHealth Exchange, they are the only health information network bringing in clinical patient data from 5 federal agencies, including the CMS, the VA, the DoD, some data from the indigenous population, as well as Social Security Administration. And they're also bringing in clinical patient data from 72 state and regional health information exchanges as well. So in totality, we're connected to over 147,000 connected care sites, 800,000 plus providers, and we're connected to all the major EMRs covering more than 92% of the U.S. geographic population with aggregated clinical patient data across 50 states and Puerto Rico. So we're in virtually every major hospital and have the most robust and comprehensive network in the interoperability space. So here's a closer look at how Patient 360 works. It's a querying engine that retrieves both complete clinical and SDOH data for each patient in real time. The clinical data is aggregated, as I mentioned, from the 3 largest data sharing networks and Commonwealth, Carrier Quality, and eHealth Exchange. You simply enter a patient's name, enter Josh, and Patient 360 scans for matching clinical and SDOH data from 147,000 care sites and thousands of consumer databases that we connect to. Once aggregated, the platform deduplicates the data for duplicates, normalizes it, and then consolidates that data into an actionable format that allows clinicians to make treatment decisions very quickly. So only seconds from searching, the network, your team then receives a complete holistic view of each patient's past medical history and future social risk. Does that make sense at a high level? So there's one thing that, I'd like to point out for you guys as, so this is a bi-directional exchange. So the only requirement typically is that, the thought is if I'm querying the network for clinical patient data, I should have something to share back. Well, you guys being in the emergency medical services space, you're not required to share back. So you're able to query the network just to pull that, patient's information in real time. Next, we're going to take a look at the user interface, and I'll start with our clinical data. We're currently looking at mock data here from our UI. Our platform presents a single longitudinal view of each patient's clinical history. So instead of leaving you to sift through a slew of unstructured data, Patient 360, we're curating that data and organizing the information in a filterable and searchable FHIR format. And Nick can talk to you a little bit more about that FHIR format if you guys have any questions when we're done with this presentation. So when we take a deeper look at how our product works with our proprietary master patient index, our national MPI works by scanning multiple systems to identify the appropriate patient using heuristic matching algorithms, referential data sources, and demographic data. With accurate patient matching, you can be confident that the data in your network is as complete as possible. You can also be sure that the clinical records, the lab results, medications, histories, and the CCDAs are linked with the correct patients. For reference, these are the data points that we use to match patients. First name, last name, date of birth, gender, home address, telephone number, and medical record number. The second step to achieving interoperability in our state-of-the-art record locator service. So together with our MPI and our RLS, making, discovering a patient's health data more efficient and accurate. With the record locator surface, it works by indexing patient record location and using them to optimize future queries. You may ask, why do I need Health Gorilla's RLS? In all likelihood, many of the networks patients have lived in a number of different locations. And with our RLS, it helps track down the medical records associated with your patients in all the places that they've lived at industry-leading speed. So ultimately, we're able to help you retrieve full patient histories without sacrificing accuracy and efficiency. Next, I'm going to pass it on over to Avery to talk about TEFCA and what QHIN means to you guys.
Yes, and I'm going to keep this fairly brief given time. Really appreciate the invite once again to speak to you all this morning. And Jonathan, I see your notes in the chat. I'll get to that right after I talk about QHIN. So I'm going to assume some base level knowledge of TEFCA and QHIN here, but essentially the federal government is setting up their own interoperability network in order to create the standards of security and data sharing that are going to ultimately help get to that long tail of data sharing that's not happening today and really inclusively create a data sharing network that folks feel more comfortable sharing for not just treatment, but other exchange purposes as well. So QHINs are the mechanism. It stands for Qualified Health Information Network. There are these super nodes in this data sharing network that ONC is setting up. So if you could go to the next slide, Marcel, and I think you can keep going forward. One more forward. I want to kind of call your attention once again to how this works. So there's a super node in the network, the QHIN you see at the top, and then ultimately folks are connecting, healthcare organizations are connecting to the QHIN. And then there's kind of an endless network effects where there are sub-participants connecting to the participants in these QHINs. All QHINs need to respond to each other once a request is made. So any QHIN that you join, you'll ultimately be getting access to TEFCA data. The differentiators between the QHINs are really going to come in the products that each QHIN offers. So for example, everything that Marcel talked about with our master patient index, record locator service, normalization, deduplication, conversion to FHIR, that is part of our kind of proprietary product on top of our QHIN access to TEFCA. So then if you could go to the next slide, Marcel, this is actually one more. This is really the point I want to hit home today for folks in the EMS space. So today, primarily, we are exchanging data for treatment. And that is all the great stuff that Marcel talked about. And so that takes care of use cases in which we have the patient identity and we're able to pull in data and treat the patient in those emergent situations. One of the big needs, as I understand it from the EMS side, is also the ability to pull in data post EHR, each ER visit, so that we can see what the outcomes were for the patient. That ultimately falls, for the most part, under healthcare operations and is something that has been difficult to get clinical data for in the past, but will be much more available once TEFCA is live, when the first QHINs are live in Q4 of this year. So there's a lot of, I think just the main thing I want to hammer home is that TEFCA is opening up new ways to get clinical data to make sure the data actually follows the patient along their healthcare journey at every step of the way, not just inside of a hospital or inside of a care clinic, but also on the truck and in other emergent situations as well. So I am going to actually stop there. And if you want to stop sharing the screen, Marcel, just so I can see people's faces for anyone that's on video, I will. Jonathan, I'm going to talk about Puerto Rico. So let me talk about Puerto Rico for a second, and then would love if there's any questions that came up either from how Health Gorilla does things today or more questions about TEFCA, we can answer that. So Jonathan, you're right. So the chat, why isn't the Puerto Rico HIE is sharing more data with EMS. So we are the tech stack behind the HIE. We don't handle any of the governance. So the governance is handled by the Puerto Rico Department of Health. So right now we have the technical ability to do that. What the Department of Health has been working on are the data sharing agreements with the hospitals in their region. So Jonathan, I'll bring that up with our HIE team and see if I can get a better answer for you on what they now responding to official requests from EMS. Yeah, so that's really out of Health Gorilla's hands, but I will definitely bring it up to our HIE team. The Puerto Rico Department of Health did have a recent change in leadership, so they're kind of working through some new initiatives with the HIE. But I know CMS is really, really supportive of the HIE and expanding the data access there. So, any questions about Health Gorilla or about TAFCA QHIN? I again really appreciate your time today.
Avery, while people are coming up with questions, one thing that I noticed is Health Gorilla put out the results of a survey just a couple days ago about, it was a survey of about 1,000 patients asking them, for what uses were they comfortable having their patient data shared. And 71% said they were comfortable having them shared for treatment purposes, but much lower percentage for payment, operations, public health. And that'll, I think, be an important thing for us to keep in mind as we need to do those operations queries to get outcomes that, we've been thinking about, well, a lot of hospitals haven't turned on, they just don't respond to operations queries. Well, we've been thinking about it from that perspective. Well, let's get the hospitals to turn that on and respond to operations queries. But there may be another layer behind that, which is that the patients don't want their data shared that way. And that's a tough one to crack too.
Absolutely. So TAFCA, the first word in TAFCA is trusted exchange framework. And that is extremely important for everything that we're doing. It's interesting in that survey that we put out, the willingness for data to be shared goes way up if you ask folks about, are you comfortable as long as the federal government is overseeing it? And so that's one thing that I'm excited about with TAFCA is it's kind of taking it out of just these random data rights contracts with individual hospitals and saying, hey, the federal government has some oversight around this. So let's make this as comfortable as possible for patients. And let's make sure that patients' privacy is respected. And looks like we have one other question in the chat. What implementation have you done with EMS? So actually, that's a really good question. And we are looking for EMS partners. So we have primarily been focused for the last few years in the telemedicine space. And so we would love to do more work in the EMS space. We have, but right now our business model has been very focused on telemedicine. So that's one reason we really wanted to engage with this group, is to figure out what that looks like going forward. So definitely very open to having continued conversations with anyone on this call.
Yeah, and one of the good things of having Health Gorilla start participating in these task force calls is that you guys will you'll learn all the nuances that EMS deals with and start to get familiar with that environment. And yes, of course, you'll bring your expertise as well. So.
Yeah, and just to give you guys an idea how this started, I met Josh at HIMSS and was finding out more about the EMS space and what you guys do, and it just blew my mind that me being a former athlete and as a young man, all the accidents I had and dealings with EMS. They say that women live longer than men, and there's a reason for that. So all the stitches and broken bones and knee surgeries that I've had. It just blew my mind thinking back to okay, so these first responders, they don't even have access to my clinical patient data. So it was it blew my mind that I never knew that. So when I got to talking to Josh and telling him more about what we do, he's like, wow. So I'm very excited to start working with you guys moving forward. We
have a question from John Murky in the chat. Asking, can Health Gorilla be used to share data over to other QHINs? He knows you can get data from other QHINs.
Yep. Yeah. Everything is bidirectional. So we help with the publication side as well. And that piece, actually, we didn't really go into it today, but that's something that, so we're acutely aware of this issue of making sure that the data gets to the doctor in the emergency department, from where you are to the doctor in the emergency department. Today, the best way to do that is direct message. But one of the hopes with TAFCA and getting everyone on TAFCA is that as soon as you post that note from the truck, you're able, the physician on the other side is able to then take in that data immediately integrated within their EHR screen. So that is one of the promises of TAFCA, but something that is definitely still will be tested as TAFCA comes live later this year.
Yeah, and right now, as it stands with our network, we've got 92% U.S. geographic coverage as it relates to all the medical records in the U.S. So when you query the network and if you share back that information, if it's any of the major EMRs, when they go to query the network, that information will be available to them. So if you're, let's say you've got an iPad and you're sharing back and to that encounter what's going on, if they go query the network, they should have that data available if they're on one of the major EMRs.
Yes, I'm just seeing a couple more things in the chat. Yes, Jonathan, thank you for reminding me. We did do an integration import export a couple of years ago, and so in general, we would love to do more of that. It's something that we've just been focused on the telemedicine market, and now especially with TAFCA, we're looking at all the ways that we can integrate the entire patient continuum, not just a telemedicine visit. And then also just wanted to, Matt said we are all bound by the policy behind TAFCA to share data with other QHINs. One thing I just wanted to mention is that participation in TAFCA will also fulfill anti-information blocking regulations. So the proposed language for information blocking, the proposed update for next year includes TAFCA as essentially a way to say that if you're participating in TAFCA, we automatically trust you, and we believe that you are not information blocking. Looks like John says, is the aggregated HG patient record then currently recognized as an actual patient data record source with associated provenance info by clinicians? Yes. So, if I'm understanding your question correctly, we track data provenance through the whole system. So you're seeing where the data came from, which clinician throughout the lifetime of the record, and then it's also tagging the provenance with your visit, so that the emergency department provider on the other side would be able to see that this is coming from you.
And John Murky had one a little above that. Publication at either or both fire resource level and document.
Yeah, so actually this is something great about the Health Gorilla, the way that they've built we call it our universal adapter, is we can convert back and forth from fire. We can give you just all the PDFs if you'd rather have a PDF, if that's easier, or we can convert everything to fire. It really depends. Most folks want to work with fire, but we can give other types of data. We could give you a stack of CCDs if that's more appropriate.
These are great questions. Keep them coming. Also, if you want to unmute and ask a question, that's fine too.
And when publishing to other QHINs, assuming that's talking about the fire resource and document. Yeah. So, wow, I love this because that's actually a very nuanced question, John. So what are the documents that are essentially being exchanged when publishing to other QHINs? And so actually fire is not required in the first version of TAFCA. So we actually do the fire conversion after the QHIN exchange. So the QHIN exchange is document-based exchange. And so we will be ingesting documents that are coming from TAFCA. This is my network that I always pull from the side of my head. So we'll be ingesting the documents from TAFCA and then converting to FHIR. And then on the back end, we can take those documents and do document-based exchange in addition to the FHIR resource exchange. It will be, so FHIR will be, they have said probably not for a year or two, but FHIR will be required at some point for QHINs.
Yeah, it's certainly one of the things that EMS software vendors have to look at is, because they're coming in, this is kind of a greenfield thing in a way. I mean, some efforts have definitely happened in the past. I'm acknowledging those, but there's potentially an opportunity for EMS software vendors to just go straight to FHIR, except that they have to be able to still interact with what's existing today. And so that's where integrators like Health Gorilla are a potential solution. So that the EMS software vendor can maybe just focus on the newest standards and rely on the fact that there'll be some translation happening on the part of the network.
Right.
Great. Well, anything else for Health Gorilla? Let's see. Oh, John had another one.
Do the Health Gorilla participants need to create a document, or does HGs do some magic from the participants' FHIR resources? So let me double check on that, because ultimately we do have to, I know that the QHIN team that built our capabilities has built the ability to do document exchange. Let me just check on the FHIR resource piece back to IHE. I believe that does happen magically in the background, but let me double check and I can get back to you. I'll email you after the meeting.
Okay, any other questions for Health Gorilla?
Awesome.
Okay,
Thank you guys. And yeah, we, Marcel, me, Nick Biela, again, who's on the call, all of us are happy to take follow-up discussions. And thanks for having us today.
Yeah, thank you all for coming and sharing that information with us and just becoming part of this effort to help EMS connect with the rest of healthcare. Okay, great. We're going to move on to the next piece here. Briefly share my screen for a second here. Oh, whoops, before I do that, sorry. I want to talk about this second topic, refining the paramedicine care flow sequence diagram. Just brief update on that. So, in June, we went through that sequence diagram. I took a bunch of notes from all of your feedback. We've been reviewing those notes. And John Murky is going to make a few updates to the sequence diagram based on the feedback and notes that we took in June. There are probably a few things in the feedback and notes that we may need to come back to this group on and say, well, this is what we wrote down, but maybe we don't have a solution figured out for this. Help us figure this out. So you should, I'm guessing you'll see some updates to that sequence flow diagram here just in the next few weeks, and then potentially coming back. We might use some time in the NEMSIS annual meeting at that interop workshop, maybe to tackle a few of the sticky issues. So that's what we're working on there. All right, so with that, I want to turn it over to Amit, who is going to give us an overview of standards and profiles. And so I'm hoping that through what he gives us, we will kind of answer these questions for ourselves, is that we'll understand what's in IHE profiles, how those profiles are structured, and how they draw on or point to or reference existing standards, predominantly HL7 standards, but there are others as well. I want to use this as a kind of a foundation for then what we'll do in August, which is we'll start diving into a specific piece of the sequence diagram, and we'll look at the IHE profiles that are relevant to that piece of the diagram. And so we'll identify the profiles to be used, maybe dig a little bit into each profile so that we have a good understanding of the scope of that profile and what standards it references. And so in order to do that, I want to make sure all of us first have just this foundational knowledge of like, what is a profile? How is it structured? What's actually in it from kind of that high level perspective, so that we can actually open up those profiles and be able to read and understand them. So that's where we're going to go with this next topic. I'll turn off my screen share, and Amit, I'll turn it over to you.
All right, well, thank you, Josh. And just give me a second and I will display my slides. Let me know when you can see those.
Looks good.
All right, so thank you all for joining our EMS Interoperability Task Force call. Thank you to the Health Gorilla team for that excellent presentation, and thanks everyone for the great Q&A as part of that as well. So as part of our ongoing discussions, like Josh said, we're going to be digging into the sequence diagram, updating, editing it in these future sessions. And as we get to that, we wanted to share some foundational information about IHE for those that may not be as aware. And so in this slide deck, I have a high-level overview on how to read an IHE profile and the components that are part of our technical frameworks. And I end the slide deck with some links and resources, including an electronic book that was published with support from ONC and developed by Audacious Inquiry and Keith Boone. And it's the IHE Profiles for Health Information Exchange ebook. And there's a link to that as well. And it's about 200 pages, and so it goes pretty in depth. But it's geared for developers who are interested in health information exchange, and it really tackles a lot of the questions in much deeper detail. But that said, let's jump into some IHE terminology so that we can all get on the same page as we continue to discuss some of this work. So IHE profiles. These describe specific solutions to interoperability problems. We specify how actors use standards to address a specific healthcare use case. So each IHE profile assigns specific requirements to specific actors. So you'll see the term IHE actors. Actors are responsible for producing, managing, or acting on the information in context of the profiles. And then finally, you're going to hear a lot about IHE domains. The domains are responsible for the development and maintenance of their IHE technical frameworks that document the integration profiles. And each domain also manages integration, its own integration profiles as part of its work. And for our EMS activities, most of the profiles we're referencing are coming from the IT infrastructure domain and then the patient care coordination domains. So we have a number of domains within IHE, and I mentioned the relevant ones at the moment for us in our discussions, especially around the sequence diagram, are ITI and patient care coordination. We also, as HIMSS, help sponsor the quality research and public health domain, as well as devices. And then our partners at RSNA support radiology. And then other sponsors across the ecosystem help support additional domains like endoscopy and eye care and pharmacy and surgery and so forth. So back to the IHE technical frameworks. So profiles are part of a larger body of work known as the IHE technical framework. Each domain committee in IHE has their own technical framework document. You can find them at ihe.net under the resources tab. So each technical framework is then divided into 4 volumes. So volume 1 provides a high-level description of the use case and scenarios, the concepts, logical system views, associated with each use case and actor, the transactions and content to be exchanged for that use case. Volume 1 is the high level. Volume 2 provides more detailed information about each transaction, including any expected behaviors for each actor, and the messages and protocols used to support the information exchange. Some of the technical frameworks volumes are pretty large, and ITI in particular is broken up into sub-volumes for volume 2. Volume 3 describes the content exchange and generally includes specific requirements on the CDA or FHIR resource, CDA documents or FHIR resources used in that exchange. And then finally, since the technical frameworks we're talking about are belong to IHG International, Volume 4 describes national extensions and restrictions that may have been added to a profile by a national deployment committee, for example, IHG USA. So digging in a little bit more into the integration profile. So the IHG profile is a specification that describes the collection of system components, which are actors, the interactions between those components, which are transactions, and then any optional behaviors that help resolve any of the interoperability challenges that we're looking at in that use case. So each actor has specific requirements. It has optional named capabilities, and that can also be implemented depending on what the use case calls for. And so back to volume 1, the core of the profile there is the actor transaction diagram. And so this is what the sequence diagrams are based off of. And they describe the software components and the interactions that participate in the use case. And so a simple IHG profile would have 2 actors, 1 transaction, like the example there. More complicated profiles will have grouped actors and options and more delineated. And so once again, the boxes represent the actors, and the lines between them are the connections representing interfaces. And so each interface will also have a name in the form of transaction name, domain ID, 3 letters, and then a number like maintain time, ITI1. And there's often also an arrow representing the direction of the interaction. The arrow comes from the requester and goes to the responder. The transaction number also happens to be the chapter number of the volume, typically, containing the transaction specification. And then finally, following any actor transaction diagrams is usually a table of actors and transactions, which indicate which transactions each actor is required to support or can optionally support.
So Meet, like in this maintain time transaction, essentially we can just see by reading it that this the information technology infrastructure domain was responsible for defining that transaction, since it says ITI.
Yep, 3-letter domain code. So ITI and PCC, as I mentioned, are the ones we'll probably be looking at through the course of this project. RAD for radiology, so forth. So you can see all the domain abbreviations, and they're pretty commonly used throughout IHE. So you'll get familiar with that pretty quickly. So let's get into more about how to read an IHE profile. So volume 2, as I mentioned, describes the interface between the actors, and those descriptions are called transactions. And so each interface between actors may require multiple interactions in order to successfully complete a transaction. So most transactions will also be described using sequence diagrams. Volume 3 is where most of the IHE domains describe any restrictions on the content or the message itself, especially when messages are complicated. And so in ITI, most volume 3 content is related to one of 3 major topics: the metadata used in cross XD profiles, XDS, XDR, XDM, so forth, the format of the document stored or how they're accessible to an HIE, and then the format of the document stored and describing what policies the patient has consented to, and also the format of a document containing a digital signature for other content. And so this consent piece will also be important going forward in health information exchange, especially at the national level. And then finally, volume 4, as I mentioned, is the content that is further constrained based on requirements made by national deployment committees in accordance with any local laws or regulation. And so, for example, in France, there may be restrictions around transmitting certain demographic information. And so that's reflected in the French national extensions for profiles. So once again, an integration profile describes the solution to a specific integration problem and documents the system roles and actors, the standards and design details for implementers. For example, PICs, PDQ. These are patient identification profiles that you're going to see all over our sequence diagram. IHE actors are, as I mentioned before, are responsible for producing, managing, or acting on any of the information in context of an IHE profile. So an actor is defined in terms of its primary responsibility. Each IHE profile assigns specific requirements to specific actors. One actor might participate in multiple profiles, and a product might implement multiple actors. Two other terms to keep in mind are transactions. So transactions, interactions between actors to communicate the required information exchange. All profiles have certain requirements. So an actor without a profile has no requirements. Document registry, for example, is referenced in transactions. An integration profile specifies requirements. It specifies transactions to be supported, any other documented behavior. And then these requirements all need further context that's given within a profile. Last two items that are around the terminology, named options. I mentioned that there are requirements as well as options that are named in profiles. And so these are functionalities an actor may choose to implement. And then there are also profile dependencies. So some profiles or actor pairs require you to also implement other actors in another profile. So for example, XDSB, for people that are familiar with that profile, those actors are required to implement a secure node or secure application actor in the ATNA profile. So a number of profiles have other profiles that they're linked to in terms of dependencies. So now I'd like to talk a little bit more about how IHE profiles relate to HL7. So one thing to keep in mind is for IHE integrating the healthcare enterprise, we profile standards across the entire ecosystem. So whereas HL7 implementation guides are really constrained to profiling only HL7. So this really speaks to the types of use cases that IHE is looking at. And so we are going beyond what a typical HL7 implementation guide would have, as we're picking up other standards as well that are usually related to a little bit more complicated health information exchange scenario. So when you say you implement IHE, that does not mean you're not doing HL7. And so usually when we hear things like, well, we don't do IHE, we only do HL7, there's usually a little bit more behind that. And so more often than not, when you implement an IHE profile, that means it's a combination of HL7 and other standards that the technical committee has selected for that specific use case and for that solution. And this is part of the overall IHE approach to designing profiles. We start with identifying and agreeing on a specific problem. Based on that problem, the technical experts conduct a standards assessment to see what's available in the ecosystem. Then there's an evaluation to select the best standards for the best use case. At that point, we begin the profiling. And then as the profiles are developed, go into trial implementation, there's opportunities to test those at connectathons. And so this results eventually in a more modular approach. So IHE, you can look at our profiles as Lego blocks or building blocks for more complicated exchanges or additional exchanges. And that's why we brought all this work to the EMS community, because we feel that there are those building blocks and profiles that are relevant to the EMS community. And so finally, remember, IHE profiles standards across the ecosystem. And although HL7 profiles and can create implementation guides, their profiles are restricted to profiling HL7. IHE profiles HL7 and beyond. And so a typical IHE implementation profile will point out which HL7 standards are referenced. And we don't stop at the publication of the profile. In fact, that's maybe where the hard work begins, because based on demand, that's when we provide formal and structured testing at connectathons. And beyond connectathons, there is opportunity to test profiles that are even further constrained to a project. And those events are called projectathons. You're probably familiar with fire connectathons. So HL7 fire connectathons. For those of you who've been to the IHE connectathons, you'll know they're a bit different. And so one of the things to kind of look at is that the fire connectathons are focused on improving the fire specifications. They can tend to be a bit more like a hackathon, which is needed, especially to improve these rapidly developing specs, but they're not the same as an IHE connectathon, where there is this expectation that the specification is implemented in a product. There's a little bit more structured testing, and there's usually more organization through the whole event to ensure there's peer testing, et cetera. And ultimately, we'd like to engage this community and convene an EMS-based projectathon to really refine these profiles. And so that's what we'll be looking at doing downstream with that sequence diagram and with the stakeholders that are interested in working on this. And so in the past, we brought up the specific EMS-focused integration profiles. These come out of the Quality Research and Public Health domain, QUIRF. And so we have the paramedicine care summary, referral interfacility patient transport, quality outcome reporting for EMS profiles that we're all looking to update and modernize, find folks to test out and bring forth through the Connectathon, Projectathon, and then showcase continuum. And finally, as I mentioned, I wanted to end with a couple of different resources. We'll make these slides available to participants, also post them on our NEMSIS IHE USA GitHub repo. And so the 4 resources I'll leave you with is 1, check out IHE.net for the overview on technical frameworks and more. For a deep dive and a great free resource for developers, check out the IHE for Health Information Exchange ebook that you can find on the IHE USA website in PDF, MOBI, different formats. And then there's the GitHub repository where we have the sequence diagram, past recordings of the EMS Interoperability Task Force, and more. And then finally, there's also IHE's YouTube channel where we've used we've created some presentations for Path to Production, then posted them on that website, and then also used some of the presentations that the domain chair co-chairs have created and brought them to the community as well. So there's for those who like to learn in different ways, you have different options as well. So with that, I'm going to just take a quick look at the chat. Thank you, John, for the update. And I will stop sharing and then turn this back over to Josh.
Thanks, Amit, for that overview. So I'll just bring up, let's see. the profiles website here, as you were talking about, there's the different domains. IT infrastructure has a lot that we'll be dealing with. Quality research and public health, that's where we're going to find the EMS profiles, right? Patient care coordination will be another important one. Those will kind of be the core ones probably for us. And then going into IT infrastructure, we see the volumes. And if I go into volume 1, I'll see all these different profiles. For example, cross-community patient discovery, right? How to find a patient. So I could go into that and start. Then I start seeing in here, it's got the actors and the transactions that you were talking about, and
I just want
the
to
requirements.
point out and give a quick shout out to John Murky and a lot of the folks within IHE that have helped convert and update some of our technical frameworks and documents to HTML. We've traditionally kept everything in PDF, and we do have a number of our stakeholders who prefer PDF only, but this is definitely helpful, and I love seeing it. So thanks again.
Yeah, and then you've also got use cases, so as you were talking about the value of IHE profiles is that you're really trying to tackle, like, how do we connect a real world use case to a set of possible healthcare data standards that are out there that could potentially be used? How do we apply that to these use cases and even these different kind of, nuances of the use case? Yeah, so opening it up for discussion and questions, would love to hear, a few things. One is any questions that you all have about IHE profiles and the topics that Amit covered. I would also love to hear, some of you who have worked with the profiles, if you think there's something important for the group to hear, and point out about these profiles, we'd love to hear from you. So yeah. Questions or additional discussion on any of this?
And we'd love to hear from folks too, if there's anything that we can tailor to specific questions in terms of what folks are looking to get out of the interoperability workshop we're going to hold at the NEMSIS annual meeting as well. So if we can get more questions, we'll make sure that we find ways to address them one way or the other.
When it says the paramedicine care summary, it still links to the 2018 document. Is that, when does the newer one come out?
Well, so that's what we're in the process of needing to do, kind of modernize some of these profiles. And one of the things we recognized as we were looking at modernizing some of these profiles was ensuring that we had the right stakeholders at the table, and which is why we're embedded with working with the NEMSIS stakeholders as well. So we can pull you guys in and get more of that feedback that we need to update these profiles and make them ready for what we're looking at.
Okay.
And as NEMSIS TAC looks at the next year of engagement with IHE, that's one of the things that we've got on the table is to make sure that there's probably a deliverable, but some time allocated to making sure that everything we've been talking about in this task force is that we start to kind of, circle that around to make updates and improvements to the profiles.
And that likely involves not only engaging this group in the monthly task force calls, but also participating in some of the technical committee work that happens at IHE. At the end of this month, we'll be having our technical and planning committee meetings out in Oak Brook, Illinois, at the RSNA headquarters. And so there'll be some opportunities there, and then of course going forward.
John Hodgson, I saw your comment. Yeah, I want to. That would be a great one to bring up. Let's right after we're done with this topic. Let's move to bring that up for a brief moment. Any other questions for Amit or people with experiences implementing these profiles?
All right. Well, if you do have other questions, please feel free to reach out. We can make sure we can address them in any future Path to Production session, at the next Interop Task Force meeting, or at the Interop workshop.
Great. Amit, thanks for that great overview of the IHE profiles. I hope that's helpful to those of you who maybe haven't looked at them before, or have tried to look at them and wondered where you were. So that's a great orientation for all of us. Let's see. So yeah, let's briefly cut over to John Hodgson's question. So he said, any insight on the open comment period for the operations query SOP and references to EMS? So John, was this one of the new TEFCA SOPs?
Yeah, exactly. So as you think about TEFCA, and they came out with the operations query and payment query that were kind of recognized as new purpose of use categories, I guess. There was I guess an SOP that was published that was open for comment for a period of time that recently closed. And just because of the situation with EMS and really wanting to get that operations query data and understanding that there's kind of a wide varied response for operations query, I'm curious about what EMS needs to do to ensure that when EMS sends an operations query into care quality or any of the other QHINs or implementers, that the request is responded to, and they understand that we're not looking for everything, right? We probably have 10 to 12 data fields that we're looking to get back that are all pretty specific to how it's outlined within the care quality implementation guide.
Yeah, I'm happy to comment on that just from the TEFCA perspective. So the SOP really follows the HIPAA guidelines around operations, so the TP&O, treatment payment operations. So we actually we meet weekly with the RCE as one of the candidate QHINs, and so that's something that we can bring up during our meetings. The RCE is intending for this to be broad, for this to include, again, elements of the care continuum that may have been missed by other types of networks. So the intention is for this to be broad. Some of this will come down to the kind of initial implementation of the QHINs and will be worked out as we sign folks up through QHIN. So it's kind of an ongoing conversation with the RCE, but I know from the RCE's perspective and from ONC's perspective, this is meant to be broad.
Okay. Yeah, and that's maybe part of my concern is the broadness of it will tend to delay what EMS is actually looking for, which is a very small piece of information. Well, and that's my thinking is, is there an opportunity to get some alignment on this is what EMS needs, and can we get the QHINs to just kind of agree that they're going to respond to those operations queries from EMS?
Well, and are you thinking a delay in terms of overall implementation or a delay in terms of time for the query to come back?
No, just overall implementation.
Yeah.
We've been talking about operations query for quite some time. The fact is that at this point, it doesn't really work, right? Nobody's really responding to it because there hasn't been any structure around it. It's, just recently approved as a new, use case, basically. I know I'm saying that the wrong way. New purpose of use.
Yes, exactly. So EMS should be, the response to EMS queries should be opted in from the beginning. So as soon as these first provider organizations go live on TEFCA, that will be part of the use case. The data that's going to come back is US CDI, essentially. So it's going to be restricted to US CDI data for those participating networks. With TEFCA, I think you're bringing up a good point. The TEFCA sets up this legal framework that hasn't necessarily existed and hasn't pushed folks to actually respond to the operations queries. But that's the whole point of the common agreement that ONC has developed in conjunction with the RCE, is that any organization that's part of TEFCA has to respond to these operational queries.
Okay, that is excellent to hear. Thank you.
Yeah, great discussion. And you know what I love that's happening here is we've broadened our relationships. In the EMS community, we've kind of not previously had a lot of connections outside of just EMS, and so Health Gorilla is there helping to develop those SOPs. No2 is there, and No2 knows about EMS, and eHealth Exchange is there, and they know about EMS. So we're getting more and more of this, ability to represent EMS at the table, and looking for even more ways to do that.
Yeah, exactly, Josh. That's kind of my concern, is making sure that as this is all being discussed, that EMS is part of the discussion. Right? We're not front and center, but we need to be part of it.
Yeah. Good. Okay. And anyone else with comments on that? Okay, great. All right. I want to look forward to the agenda for the August task force. Wanted to get input from all of you. What I have in mind is that we would start diving into the sequence diagram and pick a specific step in that sequence diagram and look at the standards and profiles that are identified to fulfill the use case of that step. So let me switch to the sequence diagram and show you what I'm talking about. So this is the high-level diagram of the paramedicine care flow. And so, beginning with a patient lookup, getting a medical summary, pushing EMS data to the hospital, getting the discharge summary from the hospital, and then delivering that NEMSIS PCR with outcome data embedded in it up to the state EMS database. And then down below here is where it goes into more detail about those steps. So what I'm thinking of, and I want to get your input here, is that in the starting in August, we would start with one of these steps in the sequence diagram and do that deep dive into it. So we would be down here in that particular part of the sequence diagram, and in particular looking at the various profiles and summaries that are identified that would be used in that interaction. So I wanted to hear from all of you, first of all, if you think that that's a good next way to go, and second, if you think it is, then what should be our priority? I don't know if we just start at the top with the patient lookup, or if we pick another piece of this as kind of our first priority of an interaction that we should dive into. So opening it up to all of you to see what you think.
By default, we were thinking of starting at the top, but we wanted to make sure we took into account everyone else's thoughts too, in case there was a burning desire to start somewhere else.
I think this is Kashif here from ImageTrend. Starting from the top is good. I know there's a lot of ask on sending and then receiving, but undoubtedly a lookup out in the field is a very valuable aspect of for the purposes of treatment to cover as well here on these calls. If I had to get specific around one of the bullet points down below, the discharge summary, I do have a couple of thoughts and questions when we do get to that I can share here for note taking for possibly future discussions. Is, for example, for the discharge summary CCDA, can NEMSIS help? I think that will help all the EMS EPCR vendors work to help plug in like the e-outcome correlation to the elements that are listed in that CCDA, so that providing mapping to EMS EPCR vendors to 3.5 e-outcome fields, for example, and parsing through the CCDA for a discharge summary. Which section are you looking for to map to? Which aspect of an e-outcome field? Because I think that will be helpful guidance with what we're trying to do here on these calls in trying to establish standards of communication and getting data across. And also thought for NEMSIS here, NEMSIS TAC and IG and folks here, is that as we're looking through the discharge summary CCDA, and we've got a wonderful set of e-outcome fields that currently exist in the NEMSIS standard. And I know there will be future larger revisions that come for NEMSIS going forward, like 3.6, 3.7. Are there opportunities to expand the e-outcome data elements based on the discharge summary CCDA, if that is the common standard for outcomes-based exchange in future NEMSIS versions, and working through on agreement on maybe if there are some good ones to expand upon that, especially with a bigger focus here on interoperability and getting outcome data back and based on standard-based documents. Those are some thoughts that I thought I'd ask.
Good. Yeah, it sounds like you'll have lots for us to think about with the discharge summary piece, which I think is right on target. Some of those things you're looking at.
Thank you, Josh.
Anyone else with thoughts on where to start? Okay. All right. So did we answer today's questions? We'll put a link to a survey form in the chat. Thank you, Lisa. We use this survey after every task force call to see how we're doing in keeping these calls relevant to you. We know we have a wide variety of participants here with different backgrounds. And so what I'd love to hear in today's survey, if you click on that link or take this QR code to fill it out, it's just a simple, like 3 questions, is, especially with the overview of the IHE profiles, like, was that right on target for you, what you needed? Was it stuff that you already knew and it was already obvious to you? Or, on the other hand, was it over your head? You need something more foundational first. We'd love to get feedback like that. And we use that feedback to adjust our agendas for the future calls. The past couple calls we just started this a couple calls ago, we've gotten 3 or 4 people submitting feedback after the call, which is nice. But if we get a few more, that'll help us to make sure we're really understanding your needs. So go ahead and fill that out as you finish from the call today. So survey, reminder about the task force email group. If you're not part of it, you can get into it in Google Groups, EMS Task Force. The GitHub repository and wiki, I just want to put in a second plug for that if you haven't seen it lately. So this is the GitHub repository where we're keeping resources that are produced as part of this effort. And in particular, the wiki link up here goes to some documentation that I've been writing up. So essentially, as we do these calls and learn things, then I'm trying to make sure that learning gets documented here. For example, the data exchange partners and networks, I'm going to add Health Gorilla as one of the potential partners here. And we'll just keep building this out as we go. This is a great way to kind of get up to speed if you've missed out on some of the past discussions as well. So don't forget to check that out. And then we'll get ready for the task force call on August 10th and the NEMSIS annual meeting towards the end of August. So with that, I think we're done for today. Amit, any parting thoughts on your end?
No, just be sure to provide some feedback anywhere you want a deeper dive. Let us know and we can arrange that. We can also go beyond IHE. Remember, we profile standards across the ecosystem, so we can pull in folks throughout the network to get the information straight from the source. So thank you everyone today. Thank you, Health Gorilla. Thanks for everyone who asked questions and participated. Really appreciate it.
Thanks everyone. Hope you have a great rest of the day.
Thank you very much.